Good morning. My name is Diane Damiano, and I'm a senior investigator at the National Institutes of Health. I'm very excited to be here today participating in Liberate 2021 and sharing my perspectives. So I've been a pediatric physical therapist for 40 years, and the last 30 years of those, I've been conducting research in close collaboration with, and also as a mentor to many engineers. I direct a laboratory at NIH that combines biomechanics, neuroscience, and neuroengineering with the primary goal of improving mobility in children with cerebral palsy. And I'm going to talk to you today about two areas. One is using mobile brain imaging and also includes neurofeedback and also rehabilitation robotics. In yellow, I've shown the staff in my laboratory who are engineers, and you can see that we're about half engineers and half clinical people. So we have a very nice multidisciplinary group to study these problems. Cerebral palsy, which is our focus, is the most prevalent motor disability originating in childhood, about 2 per 1,000. And it was said by WHO to be the highest global rehabilitation burden of any condition. And that's because it starts early in life, it lasts the lifespan, and is quite severe. CP is really a group of brain injuries or disorders with a very complex multifactorial etiology, much like autism, with some genetic factors that predispose people, but about 50% of the children with CP were born preterm. And individuals can have unilateral, bilateral involvement, and it's often a complex motor disorder ranging from mild incoordination, which we call gross motor functional classification system level 1, to complete dependence for all care, or level 5. So the big point here is that we do have some effective physical therapies in cerebral palsy. These are recent data on all the interventions and their evidence for how they improve motor function. And it's a traffic light system. So the green bubbles mean the ones that have been shown with evidence, with the size of the bubble related to how much evidence there is. This large group in yellow are ones where the evidence is weaker or inconsistent. And some of them, as you see, are rising closer to the top and are recommended. And the ones in red are ones that have been shown with good evidence to not be effective. But the point here is that even the green bubbles, the most change we can affect are typically small and moderate, and we really can't make a major change in function in these individuals. So this is where I think technology comes in to help us learn more and to develop new or novel approaches to these interventions. So I'm going to talk first about mobile brain imaging using fNIRS and EEG, which we use in our lab. And unlike MRI, we can study any functional motor task using these mobile technologies, which is very exciting for us. And the other issue in CP is about 50% of the children cannot stay still in the MRI. They have an enhanced startle response or involuntary movements. So we really can't study many of them in that way. So NIRS uses infrared light, as shown in this skull here, where it shines through the skull and then it's detected. And what we're detecting are the local changes in hemoglobin, very similar to MRI and looking at the bold response. EEG, again, also involves wearing a cap with electrodes. And as you see down below, it's recording the electrical activity across multiple channels. This is our custom NIRS probe design, and we really optimize this to cover the motor cortex, as you can see. The red are the light sources and the blue are the detectors. And we look for activity in those lines between or the channels in between. And ours covers very well the whole sensory motor cortices. And looking at that same square that I showed you before over the motor cortex, we're going to show you some data looking at the total hemoglobin differences in a group with and without CP. And we're looking at a task that's very simple. It's left ankle dorsiflexion, and you should see brain activity on the right side. The first box on your left are children typically developing. And you don't see any activity on the right side, but you see a little bit of inhibition on the left side. And often in these simple tasks, we see more inhibition in typically developing than we see activation. And then you start looking at children with the gross motor function level. So the most mild child is the GMFCS1. you start to see some activation on the right, also some inhibition, very similar in the level 2. But in level 3, these are children who are ambulatory but need assistance. The pattern changes dramatically, and you see almost the whole motor region lighting up when they try to do this very simple task. It's very hard for them to do, and they're basically recruiting all the muscles they can. And this really reflects the lack of somatotopic organization in their motor cortex. This illustration shows you why. So this is the task in the blue. They're trying to move just their ankle, and they're moving their knee. They're also moving the foot on the other side. So clearly these children are not able to isolate this movement. And when we correlated their number of muscles activated in the dark, or the EMG, with their brain activity, starting with typically developing up until GMFCS3, you see a linear relationship between these, such that muscle effort is strongly related to brain effort. And we've also been able to do some amazing things with EEG. EEG has great temporal resolution. So here we're showing data in the sensory motor cortex with areas of activation, with the size of the area related to how much. And we're also showing the real-time connectivity between those areas, timed precisely with the Gait cycle. And this is in a healthy individual, but we've also shown the same thing in children with cerebral palsy. And these are both children, GMFCS1, very mildly affected. But clearly, in the one on the left, you see very much unilateral activation for this bilateral activity. And on the other child, who looks very similar phenotypically, you see both sides of the brain being active. And this just tells us that children with CP have very individualized neural signatures of how they reorganize their brain in response to an injury. So now we've recently started an EEG study looking at early motor development in CP, again, trying to understand these mechanisms of the brain disorder in cerebral palsy and where it diverges from typical development. So let's talk a little bit about treatment. There's been quite an evolution in neurorehabilitation over the past several decades. And until about 2000, we used a very much bottom-up approach, where we thought that we could not change the brain injury, but we can change the musculoskeletal system. So in those years, I did a lot of work looking at strengthening people with cerebral palsy and improving function in that way. Around 2000, there started to be a transition. We were still using a bottom-up approach, but we also thought that maybe this bottom-up approach could reach the top. So you started seeing lots of activity-dependent exercise programs, and we thought that sensory information from motor training or from electrical stimulation could go into the spinal cord up to the motor cortex and facilitate neuroplasticity. Again, though, the changes that we were producing from those interventions were incremental. But what you're seeing emerging now will be very much more dominant in the future is more of a top-down approach. You also do the bottom-up, but now we're trying to augment that by direct brain stimulation or recording to control the external world with thoughts or enhanced training. And this includes things like deep brain stimulation, TMS, TDCS, and brain-machine or brain-computer interfaces. And we can also use the brain-computer interface technology for motor training. So instead of connecting your thoughts or your motor imagery with controlling an external device or computer, you can now use it to try to enhance your own training. So this would be a child with cerebral palsy, again, difficulty moving the ankle. And here, when they try to do it, they're either not able to do it at all, or they can just barely move their foot. And what we're seeing on the left is their sources of activity when they try to do the task, and we can isolate the motor sources and have them try to modulate those. And then what they can see is their EMG feedback, or they can see their brain activity fed back to them as well. And that is basically, we're trying to close the loop and enhance the motor training. And we can also add electrical stim or robotic device to enhance the training. And I'm going to talk a little bit about rehabilitation robotics, which we're also using in our lab. And we know that the important thing about these for rehab is that they shouldn't be developed in a vacuum, that it's really important, as discussed in this review in 2018 by Gassert and Dietz, that you need to understand the basis and the neurophysiology underlying normal and impaired sensory motor function. And And this really requires interdisciplinary coordination and knowledge. And they also talked about the history of rehabilitation robotics, which is a relatively young field, and I would argue it's even younger for CP. The first robot was really 1989 with the MIT Manus for the upper extremity. In 1994, we saw Locomat coming out. So they made the point here that upper extremity prognosis is largely dependent on this corticospinal tract integrity, and they proposed that there's actually a more flexible neural system for gait that could be altered more with robotics. And interestingly, the concept for lower limbs started with this continuous passive motion machines. But interestingly, even though there was a lot of excitement and many people bought these devices and were using these devices for therapy, they didn't seem to be as effective as we hoped. And in fact, there is a new APTA clinical practice guideline that came out last year that says that the evidence is not there to support the use of locomotor training devices for stroke, incomplete spinal cord, and TBI. So why is that? And I think to understand that, we need to go back to basic principles of neurorehabilitation. And I've distilled them down to these three words. The first is effort, that most effort has to be exerted by the person who wants to be trained, not by the device or the therapist. And the next is the person needs to be aware of and actively correct their movement errors. They need to make mistakes and see the consequences. And the third is that they need to be cognitively engaged and motivated to do the task. And I liken this to really trying to help your child do their math homework. And it doesn't help if you do the problem for them. But what does help, if you sit there as they go through the problem and they're thinking and they try different things and you may provide some suggestions and then they try that, but they have to learn what's right and what's wrong so the next time they can solve the problem themselves. So this just shows a video from the internet, and this is using a child using the Locomat. And just think of these three words. Is this child exerting effort? I would argue none at all, just sort of passively sitting in the device. Certainly not experiencing any of his own errors, and he's certainly not engaged. So you can see from this video alone why these things may not have been effective. Many of the devices, like the Locomat, use what's called assist as needed or impedance control. And what they try to do, for example, here at the knee, they would try to impose this normal knee curve where your knee flexes a little bit as you strike the ground, and then you fully extend, and then your knee flexes again in swing. And what happens here is that they are trying, when a user is in this, they're trying to learn this trajectory. And if they get out of the trajectory when they're moving, the device will sort of nudge them back into this window. And what happened, and we didn't realize that unconsciously, instead of fighting the device, which is kind of irritating to the users, they realized if they just relax and let the device move, they don't get these nudges. And what they realize is that they call it the slacking hypothesis, and they need now to provide slightly less assistance than needed. And if you do this with a different type of algorithm, that actually has been shown to be more effective. So this is the first pediatric exoskeleton for crouch gait developed in our lab, called the P-Rex. And it's basically, we use custom molded orthotics. We have a interchangeable motor assembly that can go with the knee. And we also have an FES component to facilitate strengthening and to increase the power in the knee extension assist. And our device is very different. So we're not trying to impose a trajectory. The child is generating their own trajectory. But what we do is that in the points of the gait cycle where they're supposed to be more extended, we inject a burst of torque. And that makes them more upright. And then they have to integrate that with their own motor control. And this just shows a young boy with mild crouch gait. And this typically gets worse as children age and grow. And he's a little bit worse on the left. And you can see that he's also contacting the ground with his forefoot because his knee is flexed. And here he is in our original prototype of our device. It's now all wireless with the embedded controls on the device. And I think you can appreciate that he's now more upright. He's getting a better floor strike and able to walk very well with this device. So to ask the question, can robotics improve the outcomes of rehabilitation? Well, the jury is still out, but I think it has huge potential. And the main thing that it offers is that it can give people capabilities they do not yet have. For example, if you can't dorsiflex your ankle, how can you practice doing that? You need some assistance to get you to the point where you can do the voluntary practice. It also increases the dose, reduces therapist effort. You can standardize and individualize the programs very nicely. It can bring training into the home, which eventually would make it more affordable. And we can have ways with these to increase motivation. The negatives are that you have to make sure they don't help too much and decrease effort and strength. We have to be careful about slacking. We have to be careful about altering motor learning strategies. Sometimes the reinforcement learning, people will converge on a strategy that's minimally effective instead of really exploring the full range of strategies. And right now there are high costs and accessibility issues. So my final thoughts are that rehab outcomes in CP are underwhelming, and again, in many neuro-rehab conditions. And I believe that engineering technology has the capability to alter this prognosis. I believe that real-time brain imaging will help design better interventions and may also be impactful interventions of themselves. And robotics, either assistive or rehabilitative, can potentially transform patients' capabilities and their participation in everyday life, and that we still need to develop more intuitive, personalized solutions that integrate seamlessly with voluntary motor control. So it's up to all of us to take up the gauntlet and make all of this happen. Thank you.